Tabitha Ratliff. I'm doing my presentation on folate. I chose this background because it made me think of gender reveal parties. Typically, you do like the smoke bombs or cake or pop a balloon or whatever, and folate is important during pregnancy. Overview for my presentation is a background on folate, then the study that I chose to discuss, the conclusions from that study, and then my discussion questions for this week. So, folate is also known as vitamin B6. It is a water-soluble vitamin. It used to be called folacin. It's generally found in a wide variety of food, such as leafy greens, broccoli, peas, Brussels sprouts, beans, liver, enriched foods like cereal, milk, bread, stuff like that. It's in other things as well, just not as much like eggs and some other foods. So it's pretty widely available. So if you have a well-balanced diet, you should be able to get quite a bit of it. The type of folate found in food is called tetrahydrofolate, or THF. Folic acid is the fully oxidized form. Folate is a coenzyme used for carbon transfer reactions and the synthesis of nucleic acids. The most important reactions that it's part of are converting homocysteine to methionine. The end product of this reaction is S-adenosylmethionine, which is an important methyl donor. B12 is also part of this reaction, and that's why when you have macrocytic anemia, you don't know if it's folate or B12 without doing more studies. And then it's also involved in deoxyuridylate to thymidylate. This is part of the DNA synthesis, and so folic acid or folate is required for cell division. And without it, or having a deficiency, it will cause impairment of this reaction, and you'll end up with megaloblastic anemia. So for recommended intake, it depends on age. From birth to 6 months is 65 micrograms DFE, and then it increases from there until you reach 14 years, and then it's 400 micrograms for males and females. There's no difference between males and females unless the female is pregnant or lactating. And then it depends on if you're getting the folate from food or if you're getting it from like fortified food or supplements. So if you're getting it from food, then 1 microgram DFE equals 1 microgram of food folate. If you're getting it from fortified foods like enriched bread or enriched cereals, or you're taking the supplement with food, then 1 microgram of DFE equals 0.6 micrograms of folic acid. And if you're just taking it with a supplement, or you're just taking the supplement on an empty stomach, then it is 1 microgram of DFE equals 0.5 micrograms folic acid. So 400 micrograms DFE would be 200 micrograms of folic acid. And then, like I said before, pregnancy, you want to increase the intake because folic acid is important with cell division, and if you're low, it can lead to like neuro defects like spina bifida and stuff like that. So and the lactation, you still need a little bit more, but not quite as much as pregnancy. Said before, if you're deficient in folate, you will have a macrocytic anemia, and this means the red blood cells are bigger than they should be. Symptoms of this will be similar to any type of anemia. You'll have weakness, fatigue, difficulty concentrating, irritability, headache, heart palpitations, and shortness of breath. So this is similar to like iron deficiency or B12 deficiency. And so B12 deficiency is also macrocytic anemia. So you have to make sure that you test for folate and B12 to distinguish which one it is when somebody has blood work showing macrocytic anemia. Conditions that put you at a higher risk of folate deficiency are alcohol use disorder. Typically, people who consume a lot of alcohol are filling up on the alcohol, and so they're not really eating a whole lot. And so their diet is going to be lacking nutrients such as folate. The alcohol also impairs absorption, accelerates breakdown, and increases excretion of folate. So even the small amount that the people are getting is going to be either broken down or excreted or not even absorbed. So they're at a pretty high risk of developing folate deficiency. Women of childbearing age and women who are pregnant are at risk of developing deficiency because they have, like especially pregnant women, have a higher requirement. So it is recommended that both groups take a multivitamin with folic acid. Malabsorption disorders, so if somebody isn't absorbing the folate, then obviously they're going to be at risk for having deficiency. And then MTHFR polymorphism is a disorder where you're unable to convert the folate to the active form, so then you have increased homocysteine levels. So they will, since they're not able to convert it to the active form, they're going to be deficient in the active form. Looking for a study, I found quite a few different interesting topics. I chose this one, which is about folic acid supplementation and the risk of cardiovascular diseases. It's a meta-analysis of randomized controlled trials. It was done in 2016. So the objective of the study was to analyze the existing literature to figure out if folic acid supplementation is effective for lowering CVD risk. And the research question is folic acid supplementation effective in decreasing cardiovascular disease risk by lowering homocysteine levels? Hypothesis wasn't specified, but basically they believe that folic acid supplementation will be effective. Study design, they used 3 different databases to find the articles. Medline, Embase, and Cochrane. They looked at 1,933 articles. Of those, they chose 32 randomized controlled trials with about 82,000 patients. Their inclusion criteria included that the study had to be a randomized controlled trial. The study had to have at least one heart disease endpoint, either being CVD, which is cardiovascular disease, CHD, which is coronary heart disease or stroke. CVD, CHD, or stroke events during the studies had to be reported for both the intervention and the control groups, and the intervention had to be folic acid supplementation with or without B vitamins. There were no exclusion criteria. This is showing their selection process. So they started with 1,933, and then they excluded 1,859 just by reading the abstract. They had 74 left. They excluded 44 due to either no CVD outcome, not being a randomized control trial, being a meta-analysis or review, or there being like duplicates. So they were left with 30 total. They had 22 for CVD, 25 for CHD, and 20 for stroke. For the study results, they showed that there was a 10% stroke risk reduction with a relative risk of 0.9. Confidence interval was 0.84 to 0.96, and the p-value was 0.002. There was a 4% CVD risk reduction with a relative risk of 0.96, a confidence interval of 0.92 to 0.99, and a p-value of 0.02. And there was no change for CHD. The relative risk was 1.04, the confidence interval was 0.99 to 1.09, and the p-value was 0.16. The effect on both stroke and CVD was stronger among the participants without CVD or renal disease at baseline. That showed a 20% risk reduction. This is the stroke risk graphic showing the different articles ranked from not significant to showing a risk reduction. The overall average was down here, this blue diamond, at 0.9 as the relative risk, and then the random effect was 0.88. This one shows the CHD risk. So again, these are the articles that looked at CHD, and they're listed from increased risk to decreased risk. The overall fixed effect, the average is 1.04, and the random effect is 1.04, showing that there was no significant risk reduction. And this one is the CVD risk. And similar to the stroke one, the average is to the left of the line, which is 1.0, and so the average risk reduction was 0.96 and the random effect was 0.94. This graph shows the relative risk of CVD on the y-axis and decrease in homocysteine concentration on the x-axis. So as you can see, as the amount of decrease in homocysteine increases, the relative risk of CVD also decreases. So the study discussion talked about how they showed a stroke and CVD risk reduction of 10 and 4% respectively. They also showed that CVD risk reduction was linked with decreased homocysteine levels, like I showed in the previous graph. There were previous meta-analyses that looked at stroke risk reduction. Only one in 2007 showed significance, and that was an 18% risk reduction. This study did not show a significant coronary heart disease risk reduction, and neither did any of the previous meta-analyses. The authors thought that this might be due to CHD involving large vessels, whereas stroke has a mix of different sizes, very tiny vessels, medium size, and large. So that might explain why CHD doesn't have significant risk reduction. Previous meta-analyses have shown significant risk reduction in patients with renal disease. This study did not show that, but they only had one random control trial with renal disease, and it didn't show any significance. About half of the risk reduction of stroke compared to observational studies. This study had patients with various disease states, and so that could account for that. When they did a subgroup of patients that had no CVD or renal disease, it showed a 20% risk reduction, so it was closer to that one from 2007 that showed an 18% risk reduction. And the authors think that homocysteine reduction may be more effective in earlier stages of the disease. So like before the disease gets more progressed and severe, you might have more effect on the folic acid supplementation, and you might have larger risk reductions. And then they looked at MTHFR subgroups, and it has significant difference in homocysteine reductions. Only 3 of the randomized control trials looked at MTHFR. 2 showed no significance. 1 showed some subgroups had significance for stroke reduction. For the study strengths, they only had randomized control trials, so they said that this prevented any confounding factors from being present, so they didn't need to have any exclusion criteria. They said that there was no evidence of heterogeneity in the study and no evidence of publication bias, and minimal influence of any one study on the overall results. All the studies contributed roughly equally to the results. There wasn't one that just dominated everything. For limitations, you can't completely exclude publication bias. They included only randomized controlled trials with folic acid supplementation and CVD without restrictions on study size, the treatment period, if patients had pre-existing diseases or other conditions. However, they felt that they conducted since they conducted like subgroup analyses and like took into account all of these things, and it showed no impact on the results based on, like, if you took into account study size or treatment period or pre-existing diseases and everything. They didn't think that these factors skewed their results. CVD outcomes were, the definition of that was somewhat heterogeneous, just because CVD is a pretty broad disease state. So for comparison to other studies, they included 3 new studies when compared to the most recent meta-analysis and systematic reviews on folic acid and CVD risk that were done between 2013 and 2015. So this one was the most up-to-date as of when it was done in 2016, and it included only randomized controlled trials without any restrictions. The meta-analysis that I mentioned in 2007 showed a stroke risk reduction of 18%. 10 others have been done between 2007 and 2016 and did not show any clinical significance. This study showed 10% reduction. Previous meta-analysis, 7 in total, showed non-significance in regard to CHD risk reduction. This study showed the same. 3 previous meta-analysis of randomized controlled trials showed significance for renal disease. One showed 27% risk reduction, another showed 15%, and then the third one showed risk reduction, but only for certain subgroups. This study did not show significance in renal disease, but it only had 1 randomized controlled trial that included renal disease. So in conclusion, there was a modest benefit of folic acid supplementation in risk reduction for stroke and CVD, 10% risk reduction for stroke, 4% for CVD. There was a 20% risk reduction for patients who did not have the pre-existing CVD or renal disease. There was no significant benefit or harm for coronary heart disease. For future research, I was thinking that they could look into folic acid supplementation for the risk reduction of stroke and CVD in patients at higher risk of developing these conditions without a history of either one. So look at patients with no history of stroke, CVD, renal disease, and see if folic acid supplementation will reduce the risk of developing them. And so based on the study, they were saying that maybe starting earlier before the disease has taken place and already damaged the body a lot, it might have more of an effect and have a larger risk reduction. So just looking to see if that's true. Number 2 would be compare various MTHFR variants and the response to folic acid supplementation for risk reduction of stroke, CVD, and CHD. The study showed that different variants kind of responded a bit differently, so just looking more into that and seeing if folic acid supplementation would be useful in that condition. And then lastly, examine if CHD risk reduction can be achieved, since the theory of the coronary arteries being bigger vessels and coronary heart disease having larger vessels, with it that being the reason why significance was not achieved in this study and the previous meta-analyses, looking into maybe if they need to have a higher dose of folic acid supplementation, or if they need to use more sensitive tests, or if there just is no link to CHD risk reduction at all. So just fleshing that out a little bit better. My discussion questions are: 1, based on the study, which patient subgroups would you recommend folic acid supplementation for? Which would you not? Please explain. 2, what do you think about the author's reasoning for not having any exclusion criteria? Do you agree or disagree? Please explain. What future research would you like to see in regards to folic acid supplementation and risk reduction of cardiovascular disease, and why. These are my resources. Thank you for listening.